Regarding, good evening, friends. I'm happy to start once again our info meeting this month, and we tripped on this topic very accidentally, but I think it is going to be of great interest. It is not enough if somebody keeps doing it individually and gets success or problems. So, I thought we should spread it over the whole audience, and we should get, the nuances of that and the problems, if any, because there will be people who would want to follow this also. So I try to involve other people who have been doing this, if not in great numbers, and also uh, vascular surgeons to get involved because I was not sure how they will approve this or talk against it. So we have a vascular surgeon today as a faculty, and the greatest surprise was Dr. Rick Mishler, whom I introduced to you all during the earlier meeting. He is, I should say, the pioneer or the one who started doing AV fistulas and who is continuing to do AV fistulas, because there are many who start and they end up stopping it halfway. And he was with us and he was telling the history of how things got how it grew in US. And you won't believe, I gave him this email because he's not in our group, WhatsApp group, only yesterday. So it reached him late in the night for him, and he took a note of it, and he joined at 7:30 because there was some confusion about the starting time. So I'm so glad that he is with us. Welcome you, sir. And the other faculties I have brought in are people who are doing AV fistula, nephrologists who are doing AV fistula. Dr. Adil, who is in Jammu Kashmir. He has joined this Paras Health Hospital now. And Dr. Sachin Soni from Aurangabad. These are all very vocal nephrologists who have been doing not only routine AV fistulas but modifications and uh, you know things like that. And Dr. Sumit Kapadia was introduced to me by Dr. Patel.
Hardik.
Yeah,
Hardik.
Hardik. And so I'm happy that he is around because we need to know because how much vascular surgeons would like us doing AV fistula at all on first place, and then doing all these innovations and trying to meddle more and more. So he is here with us, and I have invited some other friends also. So let's see.
So that's
Uh, Dr. Joseph Satyanathan from UK. He is also interested to join. Only thing he has some guests, but he will, I think, join and give his opinion. And the presenter is Dr. Vel Aravind. Dr. Vineet will be, sorry Vineet, there is a spelling mistake in the
no
name.
problem, sir.
After so many meetings, I don't know how my boy made it like that. You can formally introduce the speakers, then we'll go straight to Vel.
Next slide, please. Good evening, everyone. We are glad to have Dr. Vel Arvind. So, Dr. Vel Arvind Subramaniam does not require any introduction. He is the chief transplant nephrologist and intervention nephrologist from Pineapple Dialysis Center and Apollo Hospital, Trichy. And he is, most of us know him as the person who is handling the Picular Renal Transplant Group. And he is a pioneer in terms of all nephro-related and associated interventions, whether it is nephrology, transplant, or also urology. And he has developed numerous procedures. And I feel very humbled to be introducing him. And we all know about him. So looking forward to his talk. Next, please. Dr. Sachin Soni is presently working as consultant nephrologist at Medicover Hospital, Aurangabad. He is one of the senior intervention nephrologists of the country. And for the last 10 or 15 years, he has been practicing intervention nephrology and other aspects at Aurangabad. And he has been active nephrologist who is doing AV fistula and does all sorts of AV fistula, hand wrist complications, open, various techniques of AV fistula. So glad to have him here. He's also a very well-known person. So I'll not spend much time in that. Next, please. Dr. Adil Beg, he is the Director of Intervention Nephrology and Kidney Transplant at Paras Health Hospital, Srinagar, Jammu and Kashmir. After doing his training in intervention nephrology from CMC Vellore, he did a lot of work on vascular access, focus, and for the last uh, 7 or 8 or 10 years, he has been practicing in Jammu and Kashmir. Has been a great teacher and has performs all sorts of AV fistula interventions, that is including endovascular, AV fistula creation, and also has been a teacher for many of the intervention nephrologists. Glad to have him here. Next slide. Dr. Sumit Kapadia, we welcome him to our forum. His maiden joining us. So he's a senior vascular and endovascular surgeon at Adikpura Hospital, Vadodara. He's famous for his endovascular and varicose vein surgery. And after a bright academic record from Baroda Medical College, he trained his surgery at SSG Hospital, Vadodara, and subsequently did his training in vascular and endovascular surgery from the reputed Gangaram Hospital, Delhi. And he has been one of the topmost and prominent vascular and endovascular surgeons of Gujarat and the country. And he is well known all over. And we spoke that he is presently working as a vascular surgeon at Adipura Hospital. And we look forward to his perspective of this novel aspect of AV fistula. Next slide, please. So with this, without wasting much time, all the chairpersons are well known to us. We request our first speaker, Dr. Vail Arvind, to please start his session.
As Vail is sharing his slides, I'll give few words for the benefit of Dr. Rick, about the meeting and the speakers. Sir, Vail Arvind is not a mere AV fistula creator. He has gone on to other areas of, usurping a lot of surgical work, including renal transplant and transplant anastomosis. That is one thing. And that is the luxury of being in India. I think you can never imagine doing such things in your place. Then the other thing is, so this was not meant to be like this, but if you notice, the all the speakers and the faculty are from different parts of the country and not in the main, sort of not in Delhi, Mumbai, Chennai, etc. There are Vail Aravind is from Trichy, from South. Adil is from Kashmir and Aurangabad and Vadodara. So you see that things, innovations and things, a lot of activity happens in Mofussil centers. Mofussil in the mean away from the mainline centers. So I did look for, if Vinant is there, try to get people from Delhi or somebody who is interested in this. Quickly I encouraged some people, but then as such this team was formed. So just to tell you how things happen in India, and I think now we'll start with the talk, and as he goes, we can have our discussion. Yes, Vail.
Yes, sir. Sir, good evening, sir. In fact, you just gave me the heading of the topic just 2 days earlier. Recently, I had given this talk for only 6 minutes in annual Nephrology Summit, Chapter 2 at Delhi. So I'm privileged to talk again on this subject. This, in fact, I've been doing for last 2 decades, but suddenly it caught attention from some of our people, and I'll go in detail about it. So generally, our patients need care. Our care is not a perfect job delivered by some alien. I think one of the surgeons here, please don't get offended for this. It's a complete care by the nephrologist, starting from the counseling, mapping, and doing surgery and maintenance. That's what I mean here. So it's purely, if a nephrologist does a job, that makes a lot of difference. So I'll just go with some basics. Why we need this kind of valve disruption when it's against some kind of a nature we are doing. So fistula itself is some kind of things we do against nature, but why do we disrupt some kind of valve? So generally, as artery has 3 layers, vein also had 3 layers, but the valves are the peculiar one here. The valves are the crescent-shaped semilunar, emanating from or originating from the intima of the vein, covered by the outside one single layer of endothelial cells, but it contains rich collagen, and the base where it attaches to the media, tunica media, where it has a lot of smooth muscle. So that area will be a little thicker. So basically, it's a collagen with a little elastic fibers. When it joins the media or tunica media, where the smooth muscle cells will be generally excess than the normal area of the vein wall. So when you, it's a very strong one. It's a nature's a great protection. In the it's a unilateral flow. Thereby we prevent a reflux, especially in the lower limb central, very useful. So here we are going to disturb the valve mechanically. Then we'll locate a fistula. We'll ongoing slides. We'll see one by one. So in a forearm, because this makes sense, I will start from here. Some people might ask that by doing a retrograde flow, you might get a edema and other things. So we have a channels of network of channels. Vein has got a multiple connectivity between courses of the vein along its side. So we have a digital. 8 minutes. Just so we have here the digital dorsal veins. Then it goes into metatarsal veins. Then it goes in either way with basilic and cephalic vein. So this is the dorsal vein course, and the forearm veins. The dorsal veins continues as a right. The lateral side is a cephalic, and the medial side is a basilic vein, and we have a median antibrachial vein. That's otherwise known as median anticubital vein. Typically, it runs in the middle of the forearm. Sometimes it connects with a basilic vein, or it connects with a median cubital vein. You may have one vein or two median anticubital vein. This is the one which is going to be useful in reverse fistula. So this anatomical point is very important. And in a median cubital vein, that is the vein which connects between basilic and the cephalic in the cubital fossa, does not have valves. This is nature's protection. So all other veins will have a unilateral flow. Here, the flow can be on either direction between cephalic and basilic vein at the cubital. So cubital vein, there is cubital median vein will not have any kind of valves, whereas other veins will have a valves which allows a unilateral flow, only one way flow. So this is the main vein of the arm. We have a cephalic vein, brachial vein, and basilic vein. So this is the description about the cephalic vein. Cephalic vein extends from the radial side of the wrist, runs along the lateral aspect of the upper arm, then travels along the pectoral delta groove and joins the axillary vein. It is usually smaller than the basilic vein and maybe tortuous. Sometimes we can see in many of our patients, and ascends arm. And axillary cephalic vein sometimes joins the cephalic vein at the lateral border of the arm. So this is a typical about cephalic. And brachial vein is a deeper vein. It runs along with the brachial artery. And the basilic vein begins along the ulnar side of the forearm. Along its core, the other veins connect to it, maybe one or two cubital veins. The basilic vein continues in the groove between biceps brachii, especially aponeurotic. There's the biceps has got a two head. One is aponeurosis and is a tendon part. Tendon part is a radial tuberosity attachment. The fibrous part, there is aponeurosis, which spread, which goes into the deep layer of the fascia. So that is where we just sometimes open the biceps aponeurosis without any movement problems in the cubital fossa. So it runs between biceps brachii and pronator teres and ascends and crosses the brachial artery, runs up along the edges of the biceps brachii, and below the axilla, the basilic vein then travels deeper in the arm, where it joins by the brachial vein as it become an axillary vein. So this is about things, and so this is the final what I said earlier. This is I just get one picture. So why do we need reverse AV fistula? Last I think I presented this in first avatar when the history of avatar was born in India. I presented this reverse fistula, but I think they didn't get attention from many. I even demonstrated a video also. So since then, I've crossed more than 700, 800 AV fistula, reverse AV fistula. And that's not the experience I'm going to share today. So why do we need all these things? And it's not required in all patients, but some subset of patients we may require. There's a trade-off between good flow, high flow, and undesirable effects occurring in the long run. Suppose you create a brachiocephalic AV fistula. The flow is high, you are very happy, your maturation is very fast, and you have adequacy of dialysis good. But in the long run, patient may develop high output cardiac failure and even cephalic heart stenosis and aneurysmal dilatation and recirculation. So many things happens with them. It is a trade-off. So how to circumvent this kind of high output by making a brachial fistula? So here, if you have a high fistula, you have venous hypertension, you have a HD axis induced distal ischemia, you have a high output cardiac failure. I'm going to highlight that particular kind complication of high output here. Aneurysmal dilatation, we can see the serpentine like things which with grotesque amount of distortion of the upper arm with dilatation. We see cardiopulmonary recirculation. If you have a high output through the AV fistula, the faster the circulation, it never reaches the systemic. So the pulmonary recirculation will reduce the cardiopulmonary recirculation, add the problem to the heart, as well as it causes a reduction of adequacy of dialysis. So here I will highlight only one high output cardiac failure. So you know that it is anything more than 25% of the cardiac output in the fistula or exceeding 1.5 to 2 liters per minute. We may call it as a high HOHF. The symptoms could be of a dyspnea, it could be orthopnea, proximal noctural dyspnea, fatigue, swelling, and exercise intolerance. These are the cardinal symptoms we have to make you to suspect that high output cardiac failure. The physical examination will have a bounding pulse, very wide pulse pressure, warm extremities, and jugular venous distension, of course, you can see it here. And the fistula flow is higher. As I said, it's more than 2 liters per minute. And if you have a Branham, that is a Nicoladoni Branham sign, if you press the AV fistula, you have a decrease in pulse rate and increase in BP with AV occlusion. So these are the clue we may get. Then you go for a specific test, and mostly it's a clinical diagnosis. The fistula, the nature of the fistula, and then some clinical examination, some basic investigation. You come to a conclusion of HF. Then you go for reduction surgeries and all other things. That is not my talk today. So then high flow is a trigger factor for cephalic heart stenosis. Any high flow will increase the flow and the shear stress. Often it's very turbulent and flow, the altered shear stress at the cephalic hearts, believed to be contributing the development of intimal hyperplasia, which is a primary cause of stenosis. So basically, it's nature actually. It's the angulation of the cephalic vein attachment with the subclavian, in the central vein, where the sharp angle also, it's anatomically, it's not favorable in the long run. So all these things, and the valve and the presence of valve in a very acute angle, high flow, all this will produce a cephalic heart stenosis in the long run if a patient has got a very hyperdynamic flow. And this will produce a bottleneck, and this causes increased venous pressure, thrombosis, recirculation, the story goes on. So the thing is, if we have a very high AV fistula flow, the two things going to happen in long run. Even virgin side, left side, the people never attempted on any intervention like a WM catheter on. Still patients on a very virgin veins, still people develop central vein stenosis, cephalic heart syndrome, all these things because of a high flow. It's one way what I feel is the nature protects somewhere when any angulation. So when the whole flow, if it goes to the central circulation, it will produce high output cardiac failure. So nature also trying to protect one way or other. That's the reason, but it's a very inimical situation for our patients to become, because when the lifeline is disrupted, then the quality of dialysis will go, then it's a problem. So here the other reasons are radiocephalic AV fistula versus brachiocephalic AV fistula. The maturation time is shorter in a brachiocephalic fistula. That's why if you're sending a patient to vascular surgeon, they tend to do brachial fistula faster than a radiocephalic fistula, because access is very simple, big artery, quick anastomosis. Only thing you have to be a little careful about the Steele syndrome in elderly patients, smokers, all these people. Otherwise, it's very easy to do. A shorter time. In fact, I do within 15 minutes, rather in a radiocephalic fistula takes about 45 minutes. So when the distal forearm is already attempted by or some central cycline of cannulation was done, peripheral cannulation or vein thin, in this situation, we can go with reverse AV fistula. So in a flow, coming to the basic physiology, the brachial artery flow generally it's a 40 to 100 ml per minute. Average in many studies it's a 50, around 50. Immediately after BC fistula, the flow increases by 40 to 60% within 24 hours. So if you do a hand Doppler examination, then you can come to this conclusion very quickly about the turbulent flow even 6 hours after the AV fistula. So within 4 to 12 weeks, when the fistula matures, the flow can reach to in over 1000 ml or even higher. But in generally by 6 weeks, around 1300 ml, it may get in a BC fistula. Radial artery fistula, the normal flow is about 50 to 40. Average about 20 ml. It's exactly half of the brachial flow. So generally it takes a long time, but it's not in all patients, but some patients we may get a quicker radial fistula development. Majority of patients takes longer time. And especially when our setup, Indian setup, people are coming with central lines for more than 30 days, 40 days. It needs immediate removal and there is no other access problem. So we have to create a fistula which matures fast. That's the reason we often go with the brachial fistula for a early maturation and the removal of central line catheters. So in this situation, we may consider a reverse AV fistula. So this is what my crux about now. So generally we do fistula. This is here I make it a point. This is here we do normally radiocephalic fistula in this area. And the flow direction is it will either go through the sometimes through the median cubital vein or through the cephalic vein, goes through the cubital vein, it goes in the basilic vein. All this kind of a flow pattern we can see in a side to end to side radiocephalic fistula. In a patient with a brachiocephalic fistula, you see the flow direction. If you use only the median cubital vein, the flow is only one direction because this is the way that get matured. Then this is where the point of if you have a good vein like this, see if you want to use this retrograde median cubital vein, you can have more channels for cannulation. That's what I'm going to tell in this coming slides. So this is what the need for AV fistula in reverse AV fistula. So this I validated myself in a long experience in the last 2 decades of my practice, and even our juniors are convinced. One of our juniors just joined 6 months ago. He has completed 150 fistula, in which he has done more of a 40 to 50 fistula reverse AVF. He's totally convinced. So when you are learning a new technique, practice wholeheartedly until you truly understand it. I've understood clearly. That's the reason I come out with very confidently on this talk. So here the AV fistula, here if you create the thing is, see I'm cutting the basilic vein here. So cutting the proximal portion, I tie it, the distal portion, I anastomose with the end to side to the brachial artery. Sometimes you can have a flow in the basilic vein also, but most of the time we don't want that kind of destruction. We don't, but I've made an arrow. Sometime earlier I used to break the basilic vein flow also, then patient may develop edema because that's the one channel which prevents distal edema. So now I stopped doing it, but I break only this kind of, I just break this area. I'm concerned only about this area. I just break here the distal vein with using vein probes. I'll show you what are. So this is what thing is. So I just make anastomosis here and the flow will come like this. And there are multiple channels from median cubital vein to the cephalic vein. So all these things, even sometimes you can get a axillary cephalic vein also get and in a thin patients, I do side to side. Here rather instead of doing a end to side, I do side to side. Sometimes I can use the basilic vein also for cannulation in a very thinner patients. Or if I feel that all axes are exhausted, this is the only area, then I'll do side to side fistula, allow some maturation of the deeper veins. When one of the veins of the forearm veins are gone, then I may try doing a transposition of the proximal arm. So this is the way, see, as the proximal vein matures, distal vein matures. So the multiple channels, it will develop along with the deeper veins. So this is an example. This is a vein. Patients, I'm going to show now demo or some 10 videos I'll show you. So this is a thing, and the cubital fossa, the brachioradialis on the lateral side, pronator teres, this is a cubital triangle. So this is a brachial artery. So as I said, you have this is a tendon part attached to the radial tuberosity. Here is this is aponeurotic part. So it's like a fibers like this. So when you approach brachial artery, we can just cut and then half of the aponeurosis without any trouble because it's a kind of fascia. it attaches to the deep fascia of the forearm. So you can even completely disrupt it till the entire aponeurosis. So here we exposed, this is a radial brachial artery along with vena committant scene. I just pulled the, this is a basilic vein pulled apart in the lateral side, medial side, sorry. So here I just pulled it with the loop. Here I just applied a clamp here. See, this is I applied it proximally. I just applied an artery forceps, and this is a basilic vein here. I just is a basilic vein. So just so it's severe to cut, tied. So now this one is I just made up. It's a retrograde vein. I'm just getting ready. I just see whether this flow is there. I think for the beginners we want to practice this. See this there is a good flow. If it is a poor flow, there is no point in doing because the distal veins are not that much intact. So we have to make sure that the veins, even by simple palpation before doing the surgery, you can identify how many veins are patent. So even on the table, when it is covered, you cannot see the entire forearm. Sometimes we just use a round towel only to expose that area. You may not know the entire anatomy of the distal forearm. So before making a complete draping and just make assessment, see the distal veins by palpations, and all the distal veins you can make a mental picture where to go and how much pressure you can give, because the vein valves will be very prominent sometimes. A thinner vein valves, you should not break it. I'll show one by one. Okay, so this is vein probe. I'm just catching hold of the vein, the basilic vein. I'm just going to introduce it. So adjust the video. There you go. So I'm putting the probe till the mid forearm. Now I bought a probe with a longer length. I can go even distally. I can just make sorry, I'm just making it very rough of to and fro movement. It's not the way you should do it, but for the video demo, I just did it. And the vein was so, it's a pattern. And just when I go back and forth, the vein is very, the lumen is capacious enough to allow my probe to go in. So this is the thing. And once you remove it, sometimes you can disturb the valve. The valve the valve material can come along with the probe that you can see the tissue which is attached to the probe. It's a thick collagen fiber like things. So once it comes out, you are very clear that the vein is totally disrupted. So here, so I just catching hold of a lifting the brachial artery. There is a basilic vein. There is some redundancy, but we require some kind of redundancy. Then anastomosing started in the N2 side anastomosis, right? So anastomosis. So once anastomosis is over, this is the final look. And after some time, the same patient, after some time, see, it's like a AV graft like a thing, so loop like things, some channels developed. So here, this is a normal valve. It's a normal valve. It's a one-way. It's a one-way flow. Once you disturb it, there is the flow will be on either direction. So this goes up and it prevented. But once you disrupt it, I know with mechanical disruption, like this vein back and forth, and see the brachial artery is a very high flow system. Once you break open all the valves, it will keep its patency because of high flow. But you make sure that sometimes I'll not go. I'll make sure that the probe is not going only center of the valve. Sometimes I'll ride along the wall of the vein so that I can disturb the entire valve in total. So sometimes the vein may allow the probe, but soon after your brachial fistula is over, the distal flow may not be there. So I just make sure I go along with the vein wall and make sure gentle pressure back and forth and disrupt the vein wall. So there's few more videos for reverse AV creation. So this is another case, and so which is tied, and so just I'm putting a bigger probe. See, there's a Garrett probe, Garrett, Garrett. The probes are available. It's available from 0.5, 0.25 to even 3-4 millimeter. You can. So just making. I see one first go. I was not the right vein. Then I just pull it back. Then just go into the right vein. See, I'll just play again. Sorry, in the setting hanging. So the vein flows. Okay, that video is not playing well. So when as soon as there's another case, if I there's a distal flow is there, I make sure that this distal flow is there. Then I'm again putting the probe again. So you have to select the probe according to the vein diameter, so that so you need not once you break the vein, you pierce the vein wall. Soon after the clamp release, it might produce a huge hematoma. So it will take some time for you to have a feel your finger and your neocortex that like a neural connectivity should be good, where how much pressure you are giving. So that will by 1 or 2 cases you get it. So this is what that I was meaning about that this the dilators, vein probes that is called Garrett dilators available in India. It's a various size available. If you buy a set, it may be useful for many situations, right? It is starting from 0.5 to 4 millimeter. The entire set Indian rupees about 50 to 60,000, but a cheaper variety also you can buy it for 5,000. But buy the best one because the smooth surface makes sense in everything. So the same video. Okay. This is just prior to the reverse AV fistula. So after that, you know that multiple channels have developed, multiple flow direction I've shown here. So you can cannulate here. You can make the venous limb, arterial limb, anywhere you can just cannulate. A lot of points are there. So, but the thing is, when you do a reverse AV fistula, the entire volume and the brachial pressure is not going directly into the cephalic vein, into the central vein. You have multiple channels, the all pressure get dissipated. In the long run, every vein it's getting matured over the time till its full capacitance, and it all will act as a barrier to prevent central vein stenosis or all aneurysmal dilatation, anything like that. So this is once you do AV fistula of reverse, this is what the direction is like this. It will. You see, generally we have a median, anti-median cubital vein and cephalic vein. There are multiple channels. You won't see just before surgery. Once you do a surgery, after 3 for 4 months, the multiple small channels will give a good flow. Here, where that's what you should not be overzealous in doing. Probe down to the wrist level. At least we can stop till the mid forearm to just beyond the little mid forearm, so that you cannot disturb all the vein down because that might produce a dorsal wrist edema. That is a very nagging problem for the patient, and because you should not go beyond the origin of cephalic and basilic vein from the metacarpal digital to metacarpal vein. So that's the area multiple channels that will go and join the basilic vein. Now another thing is, now generally now I don't disturb the basilic vein. So the valve will be like this. They're not like this. The wall will be like this. So I don't do anything for this basilic vein for 2 reasons. I can do it for later ulnar basilic fistula. So I just keep that vein intact otherwise it will produce a severe edema on the limb. So in a nutshell, in a reverse AV fistula, it prevents the central vein stenosis. It prevents a high output cardiac failure. So this is again the same thing. So to sum it up, creation is very easy. Maturation is faster. Only thing is if you do a brachiocephalic fistula, you're bringing the angulation is a little easier. But here you have to bring the basilic vein over the brachial artery. Needs some kind of technical difficulty, but over the time, I think we can learn. This is just you have to take a spatulation down and take a little difficulty in doing, but it's all very superficial. These things we are doing in a transplant, so it's only hand. All maneuverability can be accomplished in a simple kind of changing your position. All these things. So creation is easy, maturation faster, multiple vein channels for cannulation, and rare chance of developing HYHF, a rare chance of developing cephalic or stenosis or brachial cephalic stenosis. So this I think I was a little lazy, and so Girish took it up, and published in the World Congress. This concluded in Delhi. Um, so I just tell all the people who are coming here for learning. So just things might look very odd in the beginning. It's our job doing fistula for our patients. Our job. We know our patients. We know our pathophysiology, our people, comorbid conditions, and how much they suffer financially. So if you learn, it will add it. So we should not give it up. So just keep doing for all the young people who are watching here. Probably if you are with a good mentor for 10-15 fistulas, that is a very quick learn. See nowadays, so you have a lot of access to all the knowledge. You just go and read the basics and sit with your a trainer and 10 fistulas, and then you will have a courage. So this is my teacher, H.L. Trivedi. He's a true mentor. Is hard to find. He was the one who allowed me to do fistula in the earlier, even in 1999, 2000. He said fistula can fail, but it should not complicate the patient's life. That's what the first word he said. So even if you make attempts, some patients may, your fistula may fail, but nothing going to happen if you have a radiocephalic fistula fails. You go up, but you have to apply utmost caution doing brachial fistula, especially Steele syndrome, the monomelic neuropathy and other things, acute distal ischemia. All these things you have to keep in mind. That's where you require a surgeon's help. And so this is that time I just wondering, I was just searching my photos. That time I was my boss, this 20 years later. So I just took it a few days ago in a transplant. This is one of the picture we took it in the IKDRC. I can see my boss here, uh, and this Peter Morris, and this is Feroz. There's so many other doctors are here. So this is a good memory for me. This is Haruna Manikar here. So this is my boss word. When I'm gone, if anybody wants to remember me, I wish to be remembered as a physician who cared for his patients and a patriot who cared for his country. Thank you. With this, I stop. I think it will evoke a lot of interest in you. I am ready to answer all the queries you have in your mind. Thank you, sir.
Yeah, you made it very to the point, and all the necessary steps were shown in detail with your diagrams and all the live pictures. I think now we'll pass the discussion to the other panelists and then go on to the audience. I think this is enough for people who are already doing, the information you have given them. Not only the information, the confidence start also. But now I think we should also listen to others and find out if there are any issues in this, so that we can be doubly careful and any way to even improve this. Yes, Dr. Sachin.
Yes, sir.
Dr. Yes,
Hi,
Sachin.
Tony.
Hi,
Have
sir.
you tried this?
How are you, sir?
Yeah, fine. You must remember this talk. I think I made this.
Yes, when we spoke together in Delhi, that time also you showed this. And then I did few, but I think I just put a forceps and not the Wiener's dilator, which you are mentioning.
It's a very crude way of doing it, and stop doing that. I think we have the dilators available. We call this a Gary dilator.
Mhm.
It's available. People are selling imported one. Very nice. I use it for other purposes also. I do take it for the transplant room. So various purposes I use it.
Yeah, yeah. Okay. So there is an iris holding forceps, which is like this only, sir. So I sometimes do it, but I don't have that this level of experience which you have. And this I have used as an option, but not as a routine practice. But from your presentation, it seems that after radiocephalic, before going to brachiocephalic, this can be one of the alternatives because like from forearm, you are kind of going to mid forearm instead of going to arm directly. So
Exactly.
it's a great option. Thank you for sharing. And as you mentioned, this is not technically challenging if we are doing these fistulas regularly. One potential problem which we may foresee or anticipate can be a venous hypertension, but with your great experience, it seems that it is not there. So, do you really see venous hypertension, sir?
No, nothing, nothing, Sony, nothing such kind. I never see because There are, and see, there are sometimes you have a two anti-medicubital veins. I'll just break one, which is the bigger one. But I'll tell you, the forearm veins are multiple. I have not seen any kind of, because a lot of distribution, right? So you have a cubital vein. The pressure is getting diverted in many veins. Not only you're giving one vein a flow, that might have produced multiple channels will avoid. I have not seen, to be very frank.
Well, sir, just one point, sir.
Yeah, Girish, fine.
Yeah, good evening, everyone. It's a pleasure to join and interact in this forum. So, one of our patients, you were in our institute, and one of the patients whom we had done reverse AV fistula in our institute, he's developed a profound venous hypertension and had a huge swelling of the forearm, in the sense that it initially mimicked whether the patient had any central vein stenosis. So, when we actually did Doppler and found out the root cause, so one possible thing that can happen is when you are creating these reverse AVFs, there is a perforator which connects the superficial and the deeper venous system. So, and it is very, very close to the median cubital vein, or it is very close to the elbow crease. So sometimes when for a beginner or for someone who is creating the reverse AVF for the first time, because of the angle, because the superficial and the deep perforators are connected to the cubital vein, if the perforator is passed into that perforation vein, the vein dilator is passed into that perforator, then it develops venous incompetence, and that's when venous hypertension can develop. So we have to be very much aware of the fact that if not done in a proper way, there is a good chance of developing forearm venous hypertension. But I think out of 800 or 900 cases you have done, this should be probably one or two of these cases. But it is very, very important that we identify that if there is any manhandling of the perforator vein, which connects the superficial and the deeper vein, then a forearm venous hypertension can definitely develop. But that should not stop us from doing these fistulas, because the outcomes were excellent. Out of 4 fistulas you have created in our institute, all of them we were able to. And even if such venous hypertension develops, with the newer techniques, we should be able to either coil embolize like what we do for the endovascular AVFs. So if you can coil embolize the perforator vein, which connects the superficial and the deeper venous system, then it is absolutely free of venous hypertension. But some of the vascular surgeons or some of our colleagues might have the concern of venous hypertension. So it is possible.
Yeah, you are correct.
So, although not part of reverse flow fistula, just because if some trainees are attending this, the perforating vein Girish is talking about is the vein which is used for endovascular AV fistula creation also. And it is the vein, if it is used surgically for creation of fistula, that fistula is called as Grax AV fistula. So it is not part of this reverse flow. Just for clarification, I wanted to mention.
So,
these points are well taken, sir. So I just want to add a few points what Girish said. Girish is absolutely right. That's the reason that the dilator should not go deeper. It should be in a superficial. So that point I didn't mention, but he mentioned. So I went there for INU for a few. We did some 17, maybe fistula 16, and out of which we did a 4. I think this one is just telling me the venous hypertension. So probably we would have gone down, sir.
Maybe one of us has done, and the direction would have gone down. So just a good mapping, and even intra-procedural ultrasound is very, very key for the beginners, so that you don't miss out
what
that.
Did you do, what did you do for the patient? You just close the fistula?
No, sir. We didn't close the fistula. We diverted the flow, sir. We opened up the forearm channels. So the median cubital channel and the cephalic
easier
channel.
than a central vein, right? Must be easier, right?
Absolutely. Yeah.
Okay, fine.
I have a question for the Vail, sir.
You mentioned about coil embolization.
Uh-huh.
Can we, because if it is identified, it is a perforating vein, can we not just go in and put a tie? It would be very simple, cost effective.
Yeah. Very, very much a perfect way of doing it, sir. But the problem is about the expertise. Maybe I don't have so much of a surgical expertise. That's why I looked at it. The other way is you can even put the small embolization material into that.
Yeah.
Block both the veins, with the balloons and then go to the perforator and put some embolization material. That is also possible. But yeah, the only concern is when patients develop this forearm venous hypertension, uh, how are we going to open up, because the tissue edema will be very tense, and some of the vascular surgeons express concerns that when you just give a nick on the skin also, the bleeding is little profuse. So for these concerns, I thought of proposing this endovascular coil technique, sir. That's all.
Yes. Well, can you suggest some tactile techniques by which you can avoid entering the deeper ones and
That
be
only it comes
under
by
the
experience.
supervision?
It needs experience and mental alertness. And when slow in approach, go just you should not in that one go. It should not go. It's a gentle technique, sir. So once you find there's too much resistance, you should not, because maybe end valve actually. That valve is the biggest valve of that vein, and after that the vein will be very thinner. So then you just pierce through the valve, and that's not. See, it all comes up, and there are multiple median cubital. There are two median cubital veins might be there. So you go which vein it allows to your probe to go. Then you go serial dilatation that you can do it. Sir, all well and said and done. It's only by when you do a 50 normal fistula, one can attempt this. And see, this is easy, sir. But once you do things, few cases will give you idea. So rather than me telling about everything about the nuances and the intricacies, but thing is, there should be a gentle force, gentle force. Sometimes you have to, once you find the vein, you are in the lumen of the vein, you can make a strong pressure that will disturb the valve system.
Then, if the cubital vein is long enough, can it be anastomosed with the brachial artery?
Yes, sir. That's what we routinely do, sir. That we routinely do. Sometimes the median cubital vein will not be, it can get drained into the basilic vein. Sometimes in the median cubital vein, anti-cubital vein will drain into the median cubital vein. So what I do, I go through the cubital vein and anti-medial cubital. This kind of things we can do because the probe is malleable. You can just go any direction. So, but as you said, my aim is to have a multiple channels. In long run, high output cardiac flow should not be there. Central vein stimulation. So if I prefer some patients only on dialysis a life, so most of our patients going for transplant, my patients. So if I see those patients are only dialysis a life for them, then I choose very cautious this technique, sir.
So there
Hey,
is a
Bill,
vascular surgeon doing this in great numbers in Tirunelveli also. But I have come across some puncture site aneurysms and dangerous bleeding.
That's what I'm telling, sir. But even if you puncture it, and if you that simple compression for 5 minutes, okay forever. Rarely you go and tie it. But once if you puncture it, your goal and aim is nullified. There's no point in doing that kind of. Then you have to end up with doing cubital vein brachial artery fistula, because you should be very careful. That's why I'm telling you have to buy a good instrument. Sachin said you should not use the artery forceps. That's not the right way to do it. So you have to use the proper instrumentation for that. There are beautiful instruments available, malleable one, and so even if you give force, the malleable is not a very stiff, sir. It will slip and go into the in a center of the lumen. So it's only comes by experience, but it's only need very short learning curve, very short learning curve. The vein quality of particular that patient. Then you keep doing it for some time, then it will come, sir. But it's beautiful.
Before we go to the vascular surgeon, I think Professor Rick, Dr. Rick, you can share what you see people doing in US.
Yeah, thank you. And thank you for the detailed, interesting explanation in your videos. That was very helpful. I made some notes, so I'll be checking them here to make sure I don't forget anything. The first thing that comes to mind, your technique is a looks like it's usually a basilic vein anastomosis, and that you ligate the proximal basilic vein. Is it the intention that basilic vein proximally could be used later as a transposed fistula if needed? Okay, that's good, because I'm all about saving veins, and I just wanted to clear that up because it was nagging at me going, I'm sure that's what's going on, but I needed to talk to that point. You know, we know from just long-term practice of fistulas when you've done a second and third fistulas on the same person, that you know, you'll end up looking at options where you didn't have them before, meaning you've had a proximal fistula running. It has then matured some distal veins with some kind of low flow, but over a long period of time, so that when you get back to it, you might have a distal option where you didn't have it. And I would say that we rarely see problems with forearm edema in that setting because, you know, there are multiple paths out of the forearm. So distal hypertension, you know, in a forearm with an antecubital fistula of any sort, really, be it brachial, be it proximal radial, even proximal ulnar, I think it's pretty rare, and it's, to me, it's certainly worth a trial with an anastomosis if it's sort of a perhaps a lost a last ditch effort to be able to find you know, an option for a patient, because I think the worst case is you would take the anastomosis down. What I would say is Dr. Jennings in the U.S. Proposed using a proximal radial to a cephalic vein or even a perforating vein, and then running a distal with also using valve obliteration. He used a valve. Proposed using a valvulotome, which looks like a miniature golf club where one side's got some sharpness to it. You do it just like you're doing with your dilator. You put it in and you pull it back a few times, and hopefully you come out with some shreds of valve on the end, you know, and then you get a good result. There are those people that also have very few, if any, distal valves. I've seen it happen, you know, where we hooked up, but we decided to leave things, a lot of options running at the antecubital for one reason or another, hoping something would, you know, win the race and be usable. We would then, you know, band or ligate what we didn't need to try to save it for some. And I've seen a few where, you know, they had absolutely no distal valves. They ran nicely. They were not pressurized. It was normal exam. The only odd thing was it was running retrograde and then coming back proximally through all the channels you talked about, which are a great thing. Let's see. The other thing, you're proposing using brachial, and I think that's a great idea. But even the proximal ulnar can be very useful. It tends to be bigger than a radial, and assuming you know that the distal perfusion is not in question, that is often an option as well as the brachial, and sometimes easier to get to depending on the patient's body habits, et cetera. So, but overall, I think that's a great idea. The main thing is, as nephrologist access surgeons, and I give credit to my partner, Dr. Wong, for creating that term. I use it a lot, but I think it adaptly describes what we do as nephrologists. It's our job to, you know, keep options open, think about what's still there, and even if it's kind of a long shot, so what? You know, you're dealing with these. If you can stay in the non-dominant arm for a decade or two, that's a major coup in terms of long-term vascular access. So thank you for your excellent presentation.
Well, sir, I want to ask something. So,
Yes.
if there's an ultrasonography, how you choose your patient for the retrograde AV fistula creation? What are the criteria you have?
Criteria is the pressing need of a patient, nothing else. See, if I do a mid distal or mid forearm fistula, it might take a minimum of 45 days to 60. The best matured fistula will take around 60 days, right? The same kind of thing which can be done within 20 days through the mid forearm with if as Rick Mr. said, there is many of the distal forearm they don't have veins at all. If you do here, that they all will develop, and so it's a matter of urgency. So I don't know how do you practice in our place. People are coming with the WMN catheter, non-cuffed catheter for 3 months, 4 months. So the need is where the urgency of creating a fistula and fast maturation. That's only the demand. It's not absolute scientific criteria. It's the social criteria also works here, and also in the failure in the some very thin patient, uremic, malnourished, cachectic people, if you do a distal forearm fistula, at times it does not maturation takes a long time, right? So in those situations, I'll take this thing. It's all clinical judgment. It's there is no, I have not put any criteria for this. This is a purely clinical judgment.
Okay, for sometimes there is no cubital veins or median cubital veins, and the basalic vein of arm is the basalic vein of forearm is.
Now I've changed now this kind of patients, and now I'm going for ulnar artery basilic vein anastomosis now.
Okay,
So
when there's a connectivity of the basalic vein to the basalic vein of the arm, so you create a retrograde fistula. There is a development of the basalic vein of the forearm, and you connect that with the ulnar vein.
Yeah, ulnar vein.
Ulnar artery, sorry.
Ulnar artery. See, in the first instance, I'll go with ulnar artery and ulnar artery basilic vein anastomosis. So I'm like, Dr. Kadir has done many cases in our place. I think there are options are available. I think we have to preserve as much as possible all veins which can be used in the long run. But this technique is meant. I just gave you idea because you know in a particular patient situation. I mean the clinical indication might be different. So I think you have to choose on a certain patients, right? Examination of the vein, as you said, some patient there is no cubital vein, there is no brachial cubital vein, so only the basilic vein will be there. Sometimes it will that's what you are trying to say, Adil, right?
Yeah, no. So I'm sometimes there's a basalic vein only. Why don't you choose the basalic vein if there is no cephalic vein and basalic vein of the forearm? Even so, there's only the availability of the basalic vein of the arm. At what will be your
in that case, I think you have to anastomose side to side or end to side, basilic to brachial. Then you have to transpose the art. That's the only way we can.
In those conditions, have you seen the venous hypertension of the hand and the forearm?
Since we are doing a lot of surgical work, even if it happens, either I'll close to other, go to other arm. So I'll make a quick decision. I will not pay much attention all these kind of things. Majority of times, only in our practice, in my unit, I see only the central vein causes venous hypertension. I have not seen anything related to distal forearm, to be very frank.
Probably I could understand from your technique that you are breaking the valves till the mid forearm only, and the blood is not going down. It's going it's diverting to the cephalic vein and it's going back to the.
That's why I've shown you digital veins and metacarpal veins, and till the origin of the basilic and cephalic, till that level it should not go. So you have to go the mid forearm. The channels open till the mid to the just beyond the middle. Then the channels will connect between anti median cubital vein to cephalic or something like that. So the distribution of vein will develop mosaic. See, if you fully developed cases, you'll be wondering there are so many channels have developed.
Exactly. So when I came from after training, I came back home. But I saw that the surgeons were making the fistulas of brachiobasalic, the brachial artery with the side to side basalic vein. And
okay.
in those situations, I saw the number of venous hypertension cases was huge. So every third patient probably having the same thing, that the edema of the hand with the tense hand, ulceration of the hand, and all the symptoms of the venous hypertension. So we had a meeting with the surgeons also, but their perspective was that when you made the cubital fossa fistula with the basalic vein and the brachial artery on the side to side basis, so it gives more channels, it gives long lasting fistula. But the venous hypertension was the only thing which was bothering us. So after the discussion, they have changed some technique. Now it was only, they were never creating the fistula at the wrist. So now the situation has changed probably. Now they are going more of the wrist fistulas than the previous fistula. Actually, it was a Greg's fistula, but they have modified it with the side to side fistula.
Okay.
Greg's fistula have least chances of this venous hypertension because you can have multiple channels. It's almost the same thing. Then the side to side.
Maturation takes a long time. See, many of our patients, they don't come in time. See, all the stage 4 kidney disease, ideally, you have to get everybody comes in the late stage. All access exhausted. Multiple centers in our places, peripheral centers, all the veins are touched by the other people. So this is a problem, right? So this
Yeah.
kind of situation, just you try on some patient, then we'll come out with some kind of data, and then we'll have. So I'm very comfortable with this technique. Not all patients I will go for it, but a majority of patients will go for, but 30% to 25 to 30% I'm doing reverse AFS.
So in my case,
Um,
actually, we are doing all the patients. We are going for the perm cath because it's under the government scheme.
Yeah.
We are not putting the IJVs or the temporary lines. When we are forced to do the temporary lines in the volume overload patients, others. Otherwise, we are
One
all
more
the
point,
patients. We are
Adil.
going
One
for
more point. Just we have to keep in mind now the era is changing. Now many centers are doing hemodiafiltration. So if you want to have a real hemodiafiltration, your fistula should be good. Otherwise,
yeah, yeah,
so you have to have a convective volume will be 25, 20. The last meeting they were talking about 27 liters.
yeah.
25. So in those cases, you have to have a good fistula. So I think this will be answer for everything. But I generally I don't do on the basilic side to side, as you said, and you should never break the basilic vein valves and all. So you have to only do the antecubital vein, and that will give a lot of channels for development.
Yes. Thank you.
Okay.
this is Adrian. Great presentation. Can you hear me?
Yeah. Hi. Yeah.
Can you
Okay.
hear me?
Yes, boss.
Boss. Okay, boss. Uh, uh, I had two questions. I was a bit
Sorry,
confused.
okay, I thought developer guy. Okay, yes, okay, thank you.
I was a bit confused when I heard Rick Mishler. You are destroying the proximal basilic vein. There is no way you're going to go back to create a brachiobasilic on that side. Is that correct? Is that a downside to this fistula?
Coming in.
Because you're ligating the proximal basilic, right?
Oh, yes.
So you
So,
are losing that,
okay, please go again.
not the distal, the proximal.
Yes. We tie the
So
proximal
you
one.
cannot create a brachiobasilic later on.
See, you can. Why not? See, the tight portion can be anastomosis to the brachial artery.
It
That
can.
can.
Okay,
Yeah.
I'm just asking. And
Okay.
then two questions. What is the average flow in these fistulas? And if they clot, how do you declot these fistulas?
Oh. I'll send it to one of my people who are doing this. See, so far we don't have such kind of issues, and maybe I'm not taking the entire record of every patient. So probably in the majority of patients we don't have it. Okay.
I think probably
Okay.
we'll
And
have to access through the distal cephalic channel. And then because it's a V-shaped channel, probably we can declot, sir. Retrograde access.
The whole idea of talk this to rekindle some of the hidden things. Now somebody who's doing routine fistula, they can as well start doing this, and they can come out with more of some protocol, right? That's the way. That's the reason we presented. Sir, what's the opinion, sir? Bala sir?
Well, earlier, I have anastomosed the cubital vein to the brachial artery because the cephalic vein was far away, but I was
Yes,
not sort of disrupting the veins. It used to run for some because there is a V-shaped,
yes, sir. Yes, sir. And then you have a lot of redundancy of only thing you have to cut the cephalic vein through the cubital. You can bring it some more redundancy and tension-free anastomosis. But whatever it is, sir, all the fistula will develop. It will be a super functioning fistula, sir, after some time. So that's the worry. And we have a short segment of cannulation. If it is a small in Indian patients, especially women, sir, women with very obese arms, so they have a very short segment for cannulation. And as the cephalic vein goes, it will become more superficial, and it's prone for compression, other things. So that's all. I realized that this will give a good multiple channels for our cannulation. That's what.
Yeah, one good thing I realized from your talk, and I was also contemplating this yesterday. This might prevent quite a number of central vein stenosis.
Sir, true, sir. And Girish,
Because we see
Girish,
left-sided central vein stenosis in cases where we have never cannulated the
sir,
left
that's
side.
exactly, sir, exactly.
So
Exactly. Sir, most of the time, when the left side, the side never attempted any central line anything. The reason for developing cephalic arch syndrome is high flow, sir.
yeah,
It's high flow.
and I was talking to one vascular surgeon. First, he was quite uncomfortable with this idea. Then he only suggested, see, there are cases where lower limb, vascular arterial problem and hopeless arterial system to the leg. They rupture all the veins. I mean the valves in the lower limb veins, and they anastomose the vein to the femoral artery, and that is able to perfuse the foot and keep it make it survive. So
Oh,
retrograde flow through the
okay,
lower limb
okay.
vein by spoiling the veins and making it perfuse the foot and keeping it alive. So that technique is already being practiced by some. So from that he was telling, yeah, so this may not be a sort of a wrong thing, and you know,
Sir, I did our exotic one, sir. When Girish case, I had one patient, sir. Probably I thought after 5 years retrograde fistula, we developed a venous hypertension. What I did, I took a small segment of other vein and connected between the median cubital to the cephalic vein. It's just surgically, I just did some exotic work. It worked, sir, and I just diverted the flow. Uh, I took a segment of developed vein and anastomosed between the median cubital to the cephalic vein. It's very superficial, just you needed to anastomose, that's all. So, but I think it cannot be practiced on all patients, but I think the point is, sir, when you go towards the wrist, your probe should be very superficial, not deep. And when the resistance is there, think twice or abandon the procedure and go with median cubital brachial vein anastomosis. So this you have to have some kind of you have to refrain yourself attempting further. So then slowly you will understand your cases, your ability, your outcome, and then everything will be different, sir. Because now I've started doing HDF, sir. So we need to have a high flow. We need a minimum 400 to 450 ml for a convective volume of 25 liters. So we need to have a high flow fistula, sir. So now we are moving towards HDF more and more patients, especially pre-transplant patients, sir. Patients are coming from outside, they're underdialyzed or severe pulmonary hypertension. So many problems they're having, sir. Then I put them on HDF for 10 sessions before taking them for transplant. All things reverses. So,
then those of us who are doing cath lab interventions for failing fistulas, time. I mean, there are occasions when we see that after ballooning, we think we have done a good job, and then there is a leak, and it spoils the whole show. So thinking from that, so when you are damaging the veins, were there occasions when there were disrupted veins and hematomas, and could you always manage by simply putting a tourniquet or thing, or you
a
had
10 minute compression is enough, sir. If you feel that you have pierced through the vein, a 10-minute compression is more than enough, sir. Most times we have seen once even a hematoma comes, that hematoma acts as like compressing things. So generally we require 10 minutes. They think very rarely it will go into a huge hematoma, but even otherwise, most of the patient I do retrograde AV fistula, there is a median cubital vein is intact. Actually, I'm diverting flow distally as well as through the median cubital. So my channel will be open all the other ways also. So it's I think I want to have more channels. That's all.
any other Dr. Vijay Sriramaya, Adrian, is he around?
Yes, Adrian is here.
Adrian is here.
No, Vijay has left.
Yeah, I saw his name in the list.
You can ask for the vascular surgeon, sir. He was here. I think.
Yeah, Sumit, he had some urgent work as in he has left.
Okay, sir. Okay.
I wish I had asked the surgeon who does plenty of this in Tirunelveli. I couldn't contact him. He is a plastic surgeon actually.
So actually,
But
many
in
central
fact, other vascular surgeons don't really appreciate this because it is being done by a plastic
Sir,
surgeon.
the problem why all this thing, the nephrologist should take up this job, because the running fistula is not a usable fistula, sir. So good thrill is not our aim. Actually, we should have a good flow, multiple channels, long of the fistula. All these things make sense in us. Sir, only we know our patients, sir. Most of the time, one of the nephrologists often tell me, sir, I have a thrill but no maturation for even 1 year. So you have to select it. Certain patient you have to select it. Um, so this all procedure workup is very important. The clinical context and a good clinical examination. I mean other mapping and chart down everything on a paper. Then just work on it that particular patient whether this would work in the long run. So most of the fistula we are coming here with the functioning, I mean running fistula, thrill will be there but not usable at all. So this is a
So
problem, sir.
are you all training to the guys who have been who are in the university programs? Are you all training your fellows not to just say
No.
there is a good thrill, but to examine and know what is happening? Because even though I'm in a training program right now, we're still having this problem where the fellow will come and tell there's a good thrill, and then you go and feel, and after 1 year, no one has even looked at it. It's just a good thrill, and it's not functioning. You're right.
Yes.
So we are having a problem here. I don't know if it's the same thing there because I know in India everybody loves physical exam. So I would think they would do a better job.
Okay.
Yeah,
I
I
would,
think there are two ways to look at it, sir. One is that interventional nephrology is evolving. Not many people are trained in these surveillance techniques or the simpler techniques. Then also it depends upon the interest of the residents also, because the clinical nephrology work itself is so overwhelming, and then they feel that this is the job of some specialist. So I think the way forward is if we could integrate this very much into the nephrology curriculum. And foremost thing is I dream of a day where we see fistulas being created by the nephrology residents, like they insert a IJV catheters. So simplify the process, make it easier, and by integrating all these things, I think it should be doable, sir. Yeah.
Sir, final comment, sir, and if you have 1 minute, I'll just do it, sir. Because now the present generation, sir, we have to really uh, give them a lot of space for them to get trained. The reason I'm telling, sir, because last one, as you will be agreeing with me, sir, because 2 decades of our life, the recent 5 years, we've seen a lot of pre-sensitized recipient and problem in transplant rejection. I think our focus is shifting towards good dialysis, sir. And one of our patient after rejection is living 15 years on dialysis. Now he's refusing to go back to the second transplant. So thing is, access should be good. It should be made in a right times, stage 3 and we have to educate all our young nephrologists to get trained, and they simplify the task, and they do it on stage 3 or stage 4 with a little cost to the patient, and more of a, this is the way we should go in our life, in our society. Sir, sir, 10 years before, I have not seen much rejection in our patients. Nowadays, if I do a transplant, I'm not moving out of city. We don't know next day what happens. So such kind of, some change in the paradigm is happening in immunology. So I think probably we're coming back to more of, good quality dialysis. For that, access is the nucleus of everything.
I just
We'll
want to
pick up,
add to
we'll
that,
pick up
Vail.
some questions from
There is some literature out there that if you create a fistula, the GFR decline is slower.
Yeah,
So
sir.
the
Okay.
question is, should we create a fistula earlier? Not
That's
CKD5, maybe CKD4. That's just a thought.
you have
Absolutely, sir.
to.
In fact, I advocate all my patients the same thing. I tell that by the time GFR is 20, please create an axis that will help to decrease the accelerated loss of GFR. Yeah,
yeah.
that's a well taken point, sir.
Well, this paper has been there around for a long time,
Yes,
but
sir.
no other follow-up studies on that. I think we should, people who are at least nephrologists who are doing AVFs should, collect data on patients who underwent AVF creation much earlier in life and see their,
Sir, the most
GFR.
important aspect, sir, if you allow the fistula to mature for a year, sir, suppose you create a fistula in 2024 and you are trying to take it after a year, that fistula maturation is so clean, sir. So, and it has developed all good channels, and so longer the time, the better the outcome in the longevity of the fistula. As Dan said, I think probably we should push all our patients to the early fistula, retarding the CKD progression as well as the proper maturation of the fistula. The most of the fistula problem comes when we start cannulating very early.
Yeah, the problem is that when the patient is getting more of uremia, their vessels actually the disease vessels, more of the
Exactly.
uremic vessels.
Exactly.
So when you create now what we have applied that if the patient is even not uremic, so but having the advanced uremia that urea is around 200 without symptoms. So and there's a time for the fistula creation. So what we have now practicing that we start with the this initiation of the dialysis with the perm care, and after around 3 to 4 weeks create a fistula, and then we have seen the outcome is better than the creating a fistula on that much of the urea.
Okay.
Yeah.
That's
Then there
great.
is a question in the chat box. Well,
Sir,
yeah,
we'll finish around the
valve
program.
disruption, is it not more thrombogenic?
Oh, not necessarily, sir, because as you know well, sir, because once you create a fistula after disruption, the flow is very high, sir. And we are not making it it's a single layer endothelial lining of the valve. It's not it's a very largely spaced with more of a collagen. So if you disrupt it and in the high flow, I don't think there will be a thrombogenicity
So
because
maybe there is a point because you are disrupting only the valve.
yes, sir.
Because there are occasions when I always use feeding tube to make sure the patency is okay. And sometimes when there is some resistance, I tend to use a graded feeding tube.
The wall, the intima vein intima should not be touched.
So those cases, I have ended up with early thrombosis.
Yes, sir, exactly, sir. See, here our aim is to disturb only the valve, sir. Well, that for that purpose, you should have a good, well molded, imported quality. You have to use it, sir. And you should not. Some surface will be rough, and that things will not work. You have to buy. That's worth investing on a good thing, and you just go in. You disturb the valve alone. It's just you're making, even you are not just making some kind of a hole through the valve, or sometimes you are the valve will get attached to the valve will attach to the wall. So probably there is no thrombogenesis at all. So I don't think it's a high flow system, then nothing will happen. So we are not disturbing the intima of the vein.
Okay. Before we finish, I think we
Sir,
should sort of
sir, would it,
Yeah.
Situation
excuse me, sir.
has more relevance.
Please
Like
go ahead. Okay.
whenever
One question is there, sir. Somebody's raising.
Sir,
Please.
sir, Santosh here, sir. May I, sir, just a
yes,
small
yes.
matter. Sir, this regarding what Adil sir was saying, sir. Just wanted to add, sir, that many patients after BBF creation they develop forearm edema. Actually, we have also come across many patients like that. So inevitably they'll be there. But what we realize that not everyone does transposition or supervision after BBF creation. Sometimes very lean, thin individuals, the surgeon whoever creates says that if it's okay, you go ahead and cannulate that only. So those kind of patients, what you realize, no, sir, that they don't actually transition like at the forearm basilic vein. So high flow pressure, BBAF always tends out to become high flow, sir. So that causes retrograde flow. So that causes edema in forearm. Second thing is, many a time we see 30% of the cases, the basilic vein will not directly continue as axilla and it does not join the brachial vein. Sometimes it will go and drain into the deep system near the axilla before it forms the axillary vein. In those kind of patients, even if they don't have a stenosis, because the deep system is not able to take that flow, and second thing is because the basilic in the forearm is patent, since two position is not done, it will inevitably cause edema, sir. So until we ligate the forearm basilic vein, these patients will continue to have edema. And every time edema, we had one patient, every time will come with erythema and cellulitis. Then we find out that this is the cause, sir. So I just wanted to add, sir. So
nice points, sir. Nice points.
Then whenever the cephalic vein is far away from the brachial artery, I mean, can we take this as the choice of?
First of all, we have to make a long incision, sir, and you have to bring in. However, you presume to be having a good length on table. Some kind of tension will be there in the anastomose and anything.
Plus, there will be a swing also.
So I think better to look for other choices, sir, than other choices. So on table decision is very important, sir. and on table we can make a lot of choices and decision. So that's why we should, since we can do all kind of, if you're only a vascular surgeon, a fistula surgeon, we tend to make some kind of revision and again taking the patient on some kind of thing we can do. But ultimate aim is patient should not develop complications. Fistula should run well. So these are two aims, and we can work for it. That's all.
Okay, let's see. I think over next 6 months there will be more people to give their impressions on this after practicing this in their thing. And Adil, you also had done some of this, right?
Yeah,
From what I
no.
heard from you.
For the reversal, the retrograde fistulas. No, I was actually against the retrograde fistulas due to the high incidence of the venous hypertension. So what the vascular surgeon here practices the easy, they get the basalic vein and just join it with the brachial artery and leave it. And they are saying that there is a thrill. When the patient goes back, there is no segment for the cannulation. You cannot cannulate the basalic vein, and there is no cephalic vein development. There is a basalic vein of the forearm developed. There is a basalic vein of the arm. So there is no segment for the cannulation, and they are putting the hand. Oh, there's a very good thrill. Just go and cannulate it. Where to cannulate? This was the problem with me. So I have never done this, and what I found that what the previous colleague was telling, that the perforating veins, the veins connecting from the superficial to the deeper veins, if there is a problem, there is a stenosis or there is a previous fistula was made at the wrist, and that there was the damage to the deep veins or the perforating veins, those patients are getting more venous hypertension than the new patients, one whose valsar is forming. So if there is a radiocephalic fistula, I think the side to side retrograde should not be made.
Which is the situation we should avoid? What was your
Adil, finally he said something.
Yeah, the situation when there's a failed radiocephalic fistula, or there's a handling of the deep veins of the forearm, distal forearm, we should not create a side to side or the retrograde fistula in those conditions, because the damage of the perforating veins at the wrist, or the damage to the vena comitans at the wrist or the radial veins, will lead to the venous hypertension.
Try doing things, and we'll discuss about this. And whenever it's in future meeting, we'll put out our experience more and more. And
I don't know about that, Adil, when you say radiocephalic, because if you look at our algorithm for vascular access creation by K-Doki, they will say you can, even if the radiocephalic fails, you can create an endo AVF, and we are using the deep veins at that time. And there is no problems. So if I think in your case, if you say there is venous hypertension in the arm because of damage to some veins, deep veins, that's understandable. But I don't know whether it should be specifically for radiocephalic.
Well,
yes, sir.
Can you see this picture?
Yeah, sir.
Yeah, this is one of the retrograde done by one of the surgeons here. I came across recently. This is how, I don't know whether he spoils the valves. And you
sir, say I think Rick Moss is leaving, sir. Just say thanks to him, sir. Okay, that's okay.
Yes.
Okay. Oh,
so
sir.
You see that there is retrograde flow from the cephalic vein, and it is developing the arm cephalic vein.
Yes, sir. So this is the reverse fistula, sir. Sir, I think it's a very short time you have noticed, but when the long run, it will still be more prominent, sir. It's more prominent in the center loop, like a AV graft, like loop will form. This is appreciably developed well, sir, till now. But the only thing that I make incision parallel to the arm longitudinally, not across the cubital fossa.
So longitudinal.
Long-term, sir. We just small incision enough, sir. Small incision is enough. Less than 1 inch, incision is enough.
Here they puncture the they
Yes,
pick up
sir. See,
blood
a
there and they put
median
it in the
antecubital vein can
Hmm.
be punctured for arterial cannulation, sir. And
Yes.
sir, one more thing I just forgot to tell. There's a recirculation chance is less. If you want to really recirculation, there's a
Mhm.
formula.
Yeah, you're not using the same vein segment. Yeah, right.
Yeah, exactly, sir. So you have to you have to bring down the blood flow to 50 for 15 minutes. No ultrafiltration for 1 hour. Then take the peripheral other arm vein and arterial and venous blood sample. It's a urea sample, sir. Not taking thermodilation, urea. P minus, that is a peripheral minus artery divided by P minus V into 100. If it is more than 10%, it is recirculation. But in a reverse AV fistula, since the cannulations are wide apart, you won't get such kind of things. So
The other thing, for us, when we do endo AVF creations, we actually take do a blood flow on each of those side branches that are there.
Okay.
The one with the maximum side branch, that's where we'll put the arterial needle.
Okay.
Right? Because you need the blood. If your
Yes.
veins are small, they can stick. You're not going to get that blood flow you want.
Absolutely.
So get a differential blood flow on each of these branches. The biggest one you stick as the artery. And then also it becomes important, where is the artery needle and where is the vein needle? Because the vein needle is the one that is returning. So the vein needle cannot be below the artery needle, because then the blood will just come back up and you're recirculating. So the vein needle should always be above the artery needle. Does it make sense? That's the other thing that is very important when you have all these side branches.
Okay.
I think we had a great discussion today. I think, Well, you'll have to keep a record of all your cases and get it published somewhere, so that to get rid of all the apprehensions of people who have not done this. Like, only when it is recorded and published, once you talk about this for the first
I'm trying to, some of the junior people shall come and join and take all the data out. Sir, there are enough clinical material, we can bring it out. So only thing, I'm alone, I'm doing all other work. So transplant, all these things. So getting age also now. Giving me
here on
Okay, you sound like Virat Kohli already.
Other people who can
Virat Kohli. Nahi bhaiya.
And try this in big numbers, and let us see, get follow up after a few months. Right.
I will try doing this and just give your idea, right? So you are a high volume center, you can start doing reverse AV fistula. Adil.
Yeah, sure, sir.
Yeah, but
we'll try.
Initially, I had a bad experience, because in this reverse fistula, the pressure head in the puncture site in the forearm is so high. So if there is an aneurysmal dilatation, and it becomes multiple times more than when it is in an antegrade AV fistula, because it is all only going distally. So
Sir, there are multiple channels, sir. Multiple channels, sir. I don't think. I think maybe you have created only one single channel. If there are 3-4 channels, it will be distributed, sir. So the beauty of this will be enjoyed only after 2-3 years of reverse AV fistula. So the many channels will be there, and you have a good adequacy of dialysis. You can put them on HDF 400 flow. You can get it. So, and high output cardiac failure will be null. No effect of such things can happen with the reverse AV fistula, because we have a lot of barriers to go and reach the central vein.
Yeah, I think.
Well, what is this hemodiafiltration? Why you guys are doing that? There's so much water requirements and stuff like that. I would have thought you would not want to do that.
Some see patients. I'm doing a lot of transplant. Before transplant, people are coming from periphery, underdialyzed. There's a lot of pulmonary hypertension, uremic cardiomyopathy, and malnutrition. All these things, all will 5 drugs requirement of 6 drugs. All the textbook drugs they are on, but it's still the BP not under control. So to have them to bring to neutral volume neutrality and other things, and to take out pulmonary hypertension features, to make them fit for the transplant, I put them through HDF for at least 10 or 15 sessions. It makes a lot of difference.
But why not just dialysis? I don't understand.
Just the way we practice here, but routine dialysis has been done elsewhere. but I just want to make it very safe before transplant. But if you put them through 5-10 hemodiafiltration, the pulmonary hypertension features all will come down. See, we are getting patients from outside where the dialysis is done at a government scheme, free scheme.
Yeah. Even I also heard that much, that the quality of life, in a patient on hemodiafiltration is much better. So,
Yes, sir.
but I mean,
So we have to shift our thinking towards good access, sir. Yeah, we have to make a data about this and share ideas. Sir, good night,
okay.
sir.
Thank you, everybody who joined.
I didn't good. Okay.
Thank you, sir.
Nice to see you guys again
Okay.
after a long time.
Yeah.
Thanks.
Bye-bye. Good night.
Bye.
Thank you. Good night.